Welcome to the May Town Hall training. I'm Brandy Haley and will be facilitating our training today focusing on simulation use in nursing education. Before we begin, I want to ground us in what we will accomplish during this session. Our first objective is to explain how simulation can be incorporated into the curriculum in alignment with the Arkansas State Board of Nursing Educational Standards Part 125. This means we will look at what the rules actually require, not just what is recommended, and how programs can demonstrate compliance through intentional design, documentation, and evaluation. Our second objective is to identify the required components of a systematic evaluation plan, or SEP, and discuss how to map each component to the educational standards. Many programs evaluate outcomes, but far fewer evaluate all standards as required. Today, we'll walk through how to build an SEP that is comprehensive, functional, and compliant. Our third objective is to differentiate levels of simulation fidelity and describe examples of each. Fidelity is often misunderstood as expensive equals better, but that is not the case. We'll talk about how to match fidelity to learning outcomes and resources. Our fourth objective is to apply best practice simulation standards from national organizations. These standards help programs justify fiscal, human, and material resources, which ensure simulation is implemented safely and effectively. Finally, we'll draft examples of short and long-term simulation goals, review sample policies, and discuss how simulation activities can be mapped to program outcomes. By the end of this session, you will have concrete tools you can take back to your program. Simulation is not just an optional teaching strategy. It is recognized in Part 125 as a legitimate teaching clinical learning modality. The first reason simulation matters is that it supports competency development. Students can practice skills, clinical judgment, communication, and teamwork in a controlled environment where mistakes become learning opportunities rather than create patient safety risk. Second, simulation enhances clinical judgment. We know from the NCSBN and the Next Gen NCLEX that clinical judgment is now the core competency being assessed. Simulation allows faculty to intentionally design scenarios that require students to recognize cues, analyze information, prioritize actions, and evaluate outcomes. Third, simulation provides safe, structured learning. Students can encounter high-risk, low-frequency events like postpartum hemorrhage or pediatric respiratory distress that they may never actually see in clinical. Simulation ensures equitable learning experiences across cohorts. Fourth, under Part 125, simulation must be intentionally. It must be mapped and evaluated. This means that programs cannot simply add a simulation without linking it to outcomes, documenting the activity, and evaluating its effectiveness. And finally, simulation must align with the educational standards, including curriculum design, faculty qualifications, resources, and program evaluation. Simulation is woven throughout the standards, not isolated to one section. Part 125 outlines several explicit requirements for simulation. First, simulation must be evidence-based and follow recognized standards. This means programs should align with organizations like ANASCL, SSH, NLN, NLN-SIRC. Second, programs must have qualified faculty who are trained in simulation pedagogy. This includes training in scenario design, facilitation, and debriefing, not just knowing how to operate a mannequin. Third, simulation must include pre-briefing, facilitation, and debriefing. These are not optional components. Pre-briefing establishes psychological safety and prepares students for the scenario. Facilitation guides the learning experience. Debriefing is where the majority of learning occurs. Fourth, programs must maintain policies, handbooks, and evaluation processes that describe how simulation is being used, how faculty are trained, and how simulation outcomes are measured. Finally, programs must establish short and long-term simulation goals. These goals demonstrate intentional planning and continuous quality improvement, which are required under the standards. When we talk about fidelity, we are referring to how closely the simulation replicates real clinical practice. Low fidelity simulation includes task trainers like IV arms, wound care models, or injection pads. These are ideal for teaching psychomotor skills and building confidence before students move into more complex scenarios. Medium fidelity simulation includes mannequins that have some psychological response. Maybe they can speak through a microphone, they have breath sounds, or allow for basic vital sign changes. These are useful for focused assessments and simple clinical decision making. High fidelity simulation involves mannequins with integrated software that can respond dynamically to student actions. These mannequins can simulate cardiac rhythms, respiratory distress, seizures, and more. High fidelity simulation is ideal for complex scenarios requiring teamwork and rapid decision making. Standardized patients involve trained actors who portray patients realistically. This modality is excellent for communication, mental health scenarios, and physical assessments. Virtual simulation includes VR headsets or screen-based platforms. These are increasingly recognized as valid clinical learning experiences and can supplement limited clinical placements. The key is that fidelity should match the learning outcome, not the program budget. Low fidelity simulation can be just as effective when used intentionally. A high fidelity mannequin allows students to practice complex clinical scenarios such as cardiac arrest, sepsis, or respiratory failure. These scenarios help students integrate assessment, prioritization, and teamwork. A standardized patient encounter allows students to practice communication, therapeutic interviewing, and patient education. Standardized patients are especially valuable in mental health, community health, and leadership courses. Virtual reality simulation allows students to immerse themselves in clinical environments that may be difficult to access, such as emergency departments, ICUs, or home health settings. VR is also very useful for rural programs with limited clinical sites. A skills lab with task trainers supports foundational skill development. Students can practice IV insertion, wound care, catheterization, and other procedures repeatedly until they achieve competency. Finally, a debriefing room setup is essential. Debriefing is where students reflect on their performance, analyze their decisions, and connect the experience to learning outcomes. Programs must document debriefing as part of their simulation process. Pre-briefing sets the stage for learning. It includes reviewing expectations, establishing a psychological safety area, orienting students to the environment, and clarifying the learning objectives. Students must understand that simulation is a learning experience, not a punitive evaluation. Debriefing is the heart of simulation. Research consistently shows that students learn more during debriefing than during the scenario itself. Effective debriefing includes guided reflection, structured discussion, and opportunities for students to analyze their actions and thought processes. Debriefing should be linked to competencies and outcomes. Faculty should use a structured model such as PEARLS, debriefing for meaningful learning, or the plus delta to ensure consistency. Programs must document pre-briefing and debriefing as part of their simulation records. This documentation is essential for demonstrating compliance during surveys. When we talk about simulation best practices, we're really talking about the work of several national organizations that have shaped the standards we use today. These organizations provide the gold standard frameworks for simulation design, facilitation, evaluation, and resource planning. Simulation requires intentional planning around resources, and Part 125 expects programs to demonstrate that they have adequate fiscal, human, and material resources to support simulation. Let's start with fiscal resources. This includes the budget for equipment, software, maintenance contracts, supplies, and replacement parts. Programs should be able to show that simulation is included in the annual budget, not treated as an afterthought or dependent on leftover funds. Next are human resources. Simulation requires trained faculty and ideally a simulation coordinator or a lab manager. Even if a program does not have a dedicated simulation coordinator, it must show that faculty have the time, training, and support needed to run simulation effectively. Material resources include the physical space, such as the simulation lab, the control room, debriefing room, and storage, as well as the equipment and supplies needed to run the scenarios. Programs must ensure that these resources are safe, functional, and appropriate for the curriculum. Finally, evaluation resources include the tools used to assess simulation effectiveness. This may include evaluation rubrics, student feedback forms, scenario checklists, and data systems for tracking outcomes. ASBN expects programs to demonstrate that these resources are adequate and sustainable. This is especially important during surveys where resource gaps are often identified as compliance issues. ASBN does not mandate specific goals for simulation. That is each program's academic freedom to develop. These example goals are meant to start smart conversations that you may want to have within your program. Short-term goals are goals that can be achieved within that academic year. These goals demonstrate immediate action and they progress toward compliance. One short-term goal might be to train all faculty in basic simulation facilitation by the end of the academic year. This ensures that faculty understand how to run scenarios, guide student learning, and conduct effective debriefing. Another short-term goal might be to implement structured pre-briefing and debriefing templates. This helps standardize the student experience and it ensures that required components are consistently documented. A third short-term goal example is to integrate at least one simulation activity into each clinical course. This ensures that simulation is not isolated to just one semester or one course or one faculty member, but it is woven throughout the curriculum. Finally, Programs may update their simulation handbook to align to Part 125. This includes policies, procedures, faculty training requirements, and evaluation processes. The short-term goal expectation is meant for programs to demonstrate that the program is actively working toward compliance and maintaining compliance. Then we have long-term goals. These are typically span over 2 to 5 years and they reflect strategic planning. One long-term goal example is to establish a dedicated simulation coordinator position. This role must support faculty, maintain equipment, oversee scheduling, ensure quality and consistency across simulation examples. Another long-term goal example is to develop a multi-year simulation curriculum map. This map may outline which simulation activities occur in each course, how they align with outcomes, and how they progress in complexity. A third long-term goal example is to expand virtual reality, VR, or high-fidelity simulation capacity. This may involve purchasing new equipment, renovating space, or integrating new technologies. And finally, a long-term goal example may be that some programs aim to achieve alignment with the NASCL or SSH standards or pursue accreditation or certification. While not required, these achievements demonstrate excellence and can strengthen program credibility. Long-term goals show that the program is not only meeting minimal standards, but also planning for growth and innovation. ASBN requires nursing programs to include specific content areas in their nursing curriculum. Simulation can support learning in each of these areas. In medical surgical nursing, simulation can help students practice complex clinical decision making, manage deteriorating patients, and apply prioritization skills. In maternal newborn nursing, simulation allows students to practice high-risk scenarios such as postpartum hemorrhage or neonatal resuscitation. Those are situations that they may not encounter in clinical. In pediatrics, simulation supports safe practice with pediatric medication administration, respiratory distress, and family-centered care. In mental health, standardized patients are especially valuable for practicing therapeutic communication, crisis intervention, and assessment of psychiatric symptoms. In geriatrics, simulation can address fall prevention, dementia care, and polypharmacy, common issues in older adult populations. In community health, simulation can replicate home visits, disaster response, and public health scenarios. Finally, in leadership and management, simulation can help students practice delegation, conflict resolution, and team communication. As you can see, simulation is versatile and can be intentionally mapped to every required content area. When we look across all required ASBN curriculum areas, the key is intentional integration. Simulation should not be isolated to one semester or one faculty member. Instead, it should be woven throughout the curriculum in a way that supports progressive learning. For example, in early semesters, simulation should focus on foundational skills, basic assessment, communication, simple clinical decision making. And as students progress, simulation should increase in complexity, requiring a higher level reasoning, teamwork, prioritization. Programs should also ensure that simulation activities align with course outcomes and program outcomes. This means that each simulation should have clearly defined objectives that map directly to what students are expected to learn in that course. Finally, simulation should be evaluated consistently. This includes student performance, scenario effectiveness, and faculty facilitation. These evaluations should feed into the systematic evaluation plan so that simulation contributes to continuous program improvement. Simulation must be included in that SEP because it's part of curriculum delivery, faculty qualifications, resources, and program outcomes. Under Part 125, the SEP must evaluate all parts of the educational standards, not just outcomes. This means that simulation should appear in multiple sections of the SEP. For example, under curriculum, the SEP should evaluate whether simulation activities align with course and program outcomes. Under faculty, the SEP should evaluate whether faculty are trained and competent in simulation facilitation. Under resources, the SEP should evaluate whether simulation equipment, space, and staffing are adequate. Under program outcomes, the SEP should evaluate whether simulation contributes to student learning and NCLEX success. You see, simulation is not a standalone component. It is integrated across the standards. Your SEP must reflect that integration. Many programs focus heavily on outcomes, but they overlook areas like governance, resource, or simulation. ASBN expects programs to evaluate each standard regularly using measurable indicators and documented evidence. The SEP must also include benchmarks, responsible person, frequency of evaluation, and action plans. This ensures that the program is not only collecting data, but it's also using it to make improvements. This template is a template. ASBN does not mandate a required template for SEP use. This template shows a simple but effective way to structure your SEP. Each row represents one standard or a substandard. The standard column identifies the specific ASBN requirement that's being evaluated. The indicator column describes what the program will measure. For example, student satisfaction with simulation or faculty completion of simulation training. The data source column identifies where the information comes from, such as your simulation logs, evaluation forms, or faculty development records. The frequency column specifies how often the data will be collected. Is it each semester, annually, or biannually? The responsible person column identifies who is accountable for collecting and analyzing the data. The benchmark column sets the expected level of performance, such as 90% student satisfaction or 100% faculty completion of training. Finally, the action plan column describes what the program will do if that benchmark is not met. This structure ensures that the SEP is actionable, measurable, and aligned with ASBN expectations. Mapping simulation to program outcomes is essential for demonstrating intentionality and compliance. Each simulation activity should list the specific program outcomes it supports. For example, a sepsis scenario might map to outcomes related to clinical judgment, patient safety, and communication. Faculty should use a standardized mapping form to document this alignment. This ensures consistency across courses and faculty members. Simulation evaluation data such as student performance, scenario effective, and debriefing quality should be included in the SEP. This demonstrates that simulation is contributing to program evaluation and improvement. And finally, programs should review mapping accuracy. It's up to the program to determine how often. This ensures that simulation remains aligned with evolving program outcomes, curriculum changes, and accreditation standards. As a reminder, ASBN does not tell nursing programs what their policy must say word for word. The following examples are only meant to help guide programs with policy development. This policy outlines the expectations for faculty who participate in simulation. ASBN does require faculty be qualified and understand simulation facilitation. The policy should state that all faculty must complete simulation orientation before facilitating scenarios. This orientation should include training in scenario design, pre-briefing, facilitation, and debriefing. The policy should also require annual competency validation. This ensures that faculty maintain their skills and stay current with best practices. New faculty should be monitored by experienced simulation facilitators. This may include observing simulations, co-facilitating scenarios, and receiving feedback. Finally, the policy should require documentation of faculty training in their personnel files. This is essential for demonstrating compliance during surveys. This policy focuses on ongoing professional development for faculty that are involved in simulation. Simulation is a rapidly evolving field, and faculty must stay current with best practices. The policy should require review. This may include attending workshops, completing online modules, or participating in conferences. Programs may require faculty to complete a NASCL or SIRC modules. These simulation modules provide foundational knowledge in simulation design, facilitation, and debriefing. The policy should also require faculty to maintain facilitator competencies. These may include demonstrating effective debriefing, using evaluation tools, and managing simulation technology. Finally, the policy should outline how professional development is documented and reviewed. This will ensure accountability and it supports continuous improvement. This final policy example focuses on how simulation activities are mapped to program outcomes. ASBN expects programs to demonstrate that simulation is not random or isolated. It must be intentional. It has to be connected to what students are expected to achieve by graduation. The policy may state that every simulation activity must list the specific course outcomes and program outcomes that it supports. This will ensure that faculty are designing simulations with purpose, not simply adding activities for convenience. The policy should also require faculty to complete a standardized mapping form. This form includes the scenario title, learning objectives, course outcomes, program outcomes, and evaluation method. Using a consistent form helps ensure alignment across the curriculum, and it makes it easier to review during accreditation or surveys. Another key component is requiring simulation evaluation data to be included in the SEP. This means that student performance, scenario effectiveness, and faculty observations must be analyzed and used to inform program improvement. Finally, the policy should require an annual review of mapping accuracy, at least annually. As curriculum evolves, especially with changes to NCLEX, accreditation standards, or even your program outcomes, simulation activities must be updated to remain aligned. This review ensures that simulation continues to support the program's mission and philosophy. As we bring everything together, I want to highlight the major themes we've talked about today. First, simulation must be intentional. It is not enough to simply run scenarios. Simulation must be designed with clear objectives, mapped to outcomes, and evaluated for effectiveness. Second, simulation must be mapped to the curriculum and the SEP. This ensures that simulation is integrated across the program and it contributes to continuous improvement. Third, faculty must be trained. They must be supported. Simulation requires specialized skills, particularly in facilitating and debriefing. And programs must demonstrate that faculty are competent and engaged in ongoing professional development. Fourth, programs must set both short and long-term simulation goals. These goals show how the program is planning strategically and working towards sustained excellence. Finally, documentation is essential. Policies, mapping forms, evaluation tools, and SEP entries all serve as evidence of compliance. During site visits and paper surveys, documentation is often the difference between meeting and not meeting a standard. Simulation is a powerful tool for student learning, and when it's implemented intentionally and aligned with ASBN standards, it strengthens the entire nursing program. To help programs move forward, here are some practical next steps you can take immediately. First, review your current simulation activities and identify where they are mapped to outcomes, where they are not mapped. This will help you determine whether simulation is being used intentionally or inconsistently. Second, evaluate your faculty training. Do all faculty who facilitate simulation have documented training in scenario design, facilitation, and debriefing? If not, this has to be an area you need to prioritize. Third, examine your simulation policies and handbook. Are they aligned with Part 125? Do they include mention of pre-briefing, debriefing, faculty qualifications, best practice, a framework, evaluation process, safety protocols? Do they include short and long-term goals? Fourth, review your SEP. Does it evaluate simulation across multiple standards? Are there benchmarks? Are action plans documented? Finally, begin drafting or refining your short and long-term simulation goals. These goals help guide your program's development and demonstrate intentional planning during site visits and paper surveys. Following these steps will help ensure that your simulation program is compliant, effective, and aligned with best practices. Thank you for watching this training. If you have any questions, please feel free to email me.